Hi, I'm Dr. Gil Wilshire. I'm a board-certified physician, surgeon, and reproductive endocrinologist. Welcome to my series of podcasts where we discuss medical matters that matter to you. I'll be interviewing top experts in their fields, and we'll also be delving into fascinating backstories from deep within the world of medicine. So, I'm confident you'll find the information in these podcasts valuable, and they will assist you on your journey to optimum health. Welcome to the Dr. Gil Show. This is where we talk about medical matters that matter to you. And remember, you can trust me because I'm a doctor. Today, our guest is Dr. John Miles. Welcome to the show, John.
Thank you, Dr. Gil.
Well, what a pleasure it is to have you here. In the interest of full disclosure, John has helped take care of my back over the years, so I have some personal experience with him. Also, John and I are surgical locker mates in the surgical locker room. His locker is right by mine, so our cases start in the morning. We kind of get in each other's way, but it's a nice way to check in with you and see what you're doing.
All true.
Yes, and as I'm off to do surgery and battle in the reproductive realm, John is usually going to work in the spine area. And me being very curious, I'm always peppering him with questions, and I'm just amazed by the amazing work John does. And we're going to have a talk today about the back health, back pain, and the amazing surgeries surgeons like John can do and make people's lives just generally better. So Miles, once again, welcome to the show. I want to say that you're a medical doctor. You also have a master's in business administration.
That's true.
And you are a fellow of the American Academy of Orthopaedics.
That is true.
That's a lot of initials, John. That's up there in the top of people we've interviewed here. Now, I used to be chairman of the Boone County Medical Society, and we used to meet in the Columbia Orthopaedic Group conference room there, which I think was one floor away from your office. So I had a chance to wander into your office one evening, and I looked at your diplomas, and I saw a lot of things that said Columbia, Missouri, and University of Missouri.
That is a fact. A pretty local product.
Yeah, you came. Were you born in Columbia?
I was not. My dad was a mechanical aerospace engineering professor, and I was born in Champaign, Illinois, where he was getting his PhD. And then shortly thereafter, after a short stop in Carbondale, the family moved to Columbia, Mo, where I grew up.
You know, Champaign, Illinois. You know what that's famous for in my memory?
Dick Butkus?
Maybe, but in addition to that, you might remember the movie 2001: A Space Odyssey. The HAL computer was built in Champaign, Illinois.
Was it really?
Yeah, it comes out as they're deprogramming him near the end of the movie. He talks about his beginnings, and HAL is one letter. It's one letter from IBM. It's HAL. Very interesting. So I'll always remember that. So you went to undergraduate at University of Missouri, and you got a bachelor's of science in mechanical engineering.
That is true.
So were you always mechanically oriented or interested?
Not really. I've told the story a few times. I was kind of the typical disaffected teen, and I really didn't know where I was even going to go to college, and I kind of procrastinated. And I went over to sign up for classes at Mizzou. Actually, my dad made it fairly simple for me. He said, I've already paid taxes at the university, so I'll pay for that. You can go anywhere you want on your own ticket, unless you've distinguished yourself academically at such a level that there's not a professor at that institution that can really stimulate your intellectual pursuits. So we could check that one off pretty quickly as a non-starter. So I went over to the university. Did not used to be very consumer friendly. So the way you signed up for classes, there was a big stone building over there Brewer Field House that was not air conditioned. So you went over there in August with a few thousand of your best friends and stood in lines to sweat a lot. And then when you got to the front of the line, they had like a punch card system. And then you'd get to the front of the line and they may or may not have a spot for you in that class. And if they didn't have a spot, you just went to the end of another line and for this process. So I was fairly fed up with that as a freshman, and I walked over to my dad's office to complain about this horrible process that they were putting us through. And I knew I wasn't getting any sympathy, but on the way by the dean's office, I noticed that there was a few young people that were in a little short line in the dean's office. And I opened the door, and it was air conditioned.
Okay.
Which was a good sign.
Good sign.
And there was a short line, which was a good sign. And I asked the secretary, I said, could I sign up for engineering school in this line? She said, yeah. I said, oh, that's my line.
There you go. The hand of God.
Yeah. So that's how scientifically I selected mechanical engineering.
Now, did you know when you were younger that you wanted to be a doctor? Did that come later?
My grandparents thought I should be a doctor. My parents thought I should be a doctor. My grandmother always told me I had doctor hands. John David, you should be a doctor. And I didn't really know what I wanted to do, but my dad was a mechanical engineer. His dad was a mechanical engineer. So my grandfather was the dean of the engineering school down in Raleigh.
Okay.
And then my dad was a mechanical aerospace guy.
So do you recall a moment when the bug got you when you said, I want to be a doctor or I want to be a surgeon? Was there a moment?
Well, as you know, I didn't go right into medicine. So I got an MBA after I knew I didn't want to be an engineer.
All right, so you hadn't made the decision yet. So after you got your bachelor's degree, you said, hey, I'm going to be more business-minded.
More business-oriented.
You got an MBA. That's 2 years in MBA?
It was
year and a half.
Year and a half. I had enough credit hours, and I took a whole bunch of summer school classes. I was kind of used to getting my butt kicked, so to speak, in engineering school. Going to business school wasn't.
Engineers are tough.
That bad, yeah.
Tough class.
So I got it pretty quick, and then I started to work and had a few different jobs, and I actually liked what I was doing all right.
But something must have bit you, John, because then you went to medical school.
I did, with 2 kids on the ground already.
So you had some responsibility you needed to earn. And was there a moment you said, hey, I want to be a doctor? Or did you know you wanted to be a surgeon or an orthopod?
I really wasn't that calculating. I thought I'm probably going to be good at anything with tests, with standardized tests.
Okay.
And I had good hands. I knew that.
You knew that.
And I thought, well, if I can take tests well and have good hands, that means I could be a surgeon.
Okay.
And I thought, well, there's something noble in that. And you can chart your own course.
Mm-hmm.
I didn't think I was that lucky. And I didn't have a pot of money coming my way that I could get equity in a company or something. So I thought, well, I could help people. Maybe I'm good at it. And so we'll give it a go.
And when in medical school, the 3rd or 4th year, or did you decide you were going to be an orthopedic surgeon, or was that right off the bat?
I thought orthopedics from the beginning. You can't tell anybody that because that's the evil. That's the evil specialty. You can't. You got to keep that under your hat.
Now, were you a jock? Were you athletic?
I was.
What did you play? Baseball?
I was a tennis player.
Tennis. I could see you playing tennis. You got the Djokovic look to you.
Tennis was kind of in its heyday when I was a youngster. A lot of popularity.
So for medical school. Now, was that in the days when you applied to an orthopedic residency and then had to do a year of general surgery anywhere, or was that kind of wrapped together?
You could do it anywhere, but at the university it was wrapped up. And Dr. Allen gave me a spot outside of the match, which was more common back in the day.
Right.
So there's this, as you're well aware, there's this match process. And with 2 kids already and a 3rd one on the way, and you get a spot, I just thought, well, I'll just take the spot.
Did the right thing. So you did a year of general surgery, which is always a great idea. I think any doctor should do a year of general surgery.
You get to see some stuff you'll never see again.
You never see again. And then you did 4 years of orthopedic surgery here at University of Missouri.
Correct.
A lot of great orthopedic surgeons here in Columbia. And when in your orthopedic residency did you get the bug that maybe the back was going to be your subspecialty?
Well, there was a very internationally well-known spine surgeon at the University, a fellow named Bob Gaines, who became my mentor. Bob is famous for a lot of reasons. A lot of stories about Bob. The reality is most residents didn't like it, spine surgery, so I had a lot of opportunities to do it. And Bob, for some reason, took a liking to me. So I was literally putting in pedicle screws as a fourth-year med student, which in retrospect is not certainly an extreme outlier situation.
Well, you must have shown talent and promise, because I sniff it out in students. You can kind of tell what they're good at. So they were already grooming you, I guess. So at the end of your orthopedic residency, you did a year of special spine training down in Plano, Texas?
Correct.
What was the name of that place? The Texas Back Institute?
Texas Back Institute, which is a high-power place. They do a lot of research. It's kind of a unique animal because it's a private practice that produces an extreme amount of clinical research.
They had this joke about specialists. You know more and more about less and less until you know everything about nothing, you know? So I see from the description on your website and your personal information that you have become the specialist in adult degenerative conditions of the spine.
Well, that's true that most of us do adult degenerative.
We have no choice because we're all degenerative.
That's what
right?
we get around here. We'll do young people, but pure pediatric orthopedics is really tough to do in private practice. And there's actually an exceptionally good fellow over at the university.
So we send the pediatrics.
Yeah,
right. Well, that makes sense.
Dan Hornschmeyer is his name.
Yeah, I know Dan.
Yeah, really good guy.
Really good guy, and that's what he specializes in. So you're taking care of us older folks, and I notice you've been even more specialized to the neck and the lumbar. Do you leave the middle back maybe?
Well, the middle back doesn't get much attention, and it doesn't need it because the only reason you operate on the thoracic spine for the most part is scoliosis.
Okay.
And scoliosis is another niche play that is best done probably in an academic center. And again, Dan Horschmeyer does a great job with scoliosis patients. Bob Gaines did before him at the university. Missouri is a weird state because honestly, when I was in training, 3 of the best known scoliosis surgeons probably in the world were in the state of Missouri.
Interesting.
There was Larry Linke and Keith Bridwell at WashU, and there was Mark Asher at KU, and Bob Gaines at the University of Missouri. So, and there's not that many of these cases around. Okay, so these people, the patients were coming from all over the country.
Yeah.
Because 3 really heavyweight guys in the world of scoliosis.
That's really great to know as a resource. So I like these podcasts to be practical and helpful to almost anyone. I want to have a very wide general audience. And I'd like to point out that from my reading, it looks like back pain is the #1 cause of disability or workers' comp or in this country.
That's true.
Wow, very, very common. So we all get it. I'm sure there's probably every human's had a backache at some time or another. So let's talk about back health in general. Let's say I'm a young, healthy adult. Is there anything we can do to keep our backs healthy? For example, talk to me a little bit about beds and mattresses. I'd like to talk about basic activities one can do. And maybe we can talk about basic exercises one can do to keep one's back healthy.
Well, if we're talking about the low back, there's a lot that can be done. At the top of the list is probably just to maintain a physiologic weight is big. But we talk all day in clinic about core strength, which is the belly and the back muscles. And the stronger that a patient can make their core muscles, they're going to hurt less and be able to do more. And contrary to popular belief, we almost never operate on people for back pain. We operate for people that may have back pain, but they also have buttock and leg pain, typically with numbness, tingling, weakness.
I wanted you to get into that, the signs of a back problem. but sticking with overall health. So we want to keep a normal weight if we can, and have a strong core. Are there any kind of activities? I bet you tennis was good for your core.
Tennis is good for people. As we get older, some of these things are tougher to do. I'm a big proponent of water aerobics for a lot of senior people. It's kind of a perfect exercise medium. You're buoyant in water, so it unloads all your joints, and yet every movement is resisted by the water. So a great resource if it's available. A lot of the smaller towns in Missouri don't have that resource. Columbia, we do. Several options here locally.
Is swimming in general maybe good for your core?
Great. It's really hard to get people to swim. A lot of people don't swim.
Okay.
So the default is water aerobics, but I think you get really the same benefit.
All right. When I was having some back pain issues that, in fact, were not surgically related, they were musculoskeletal. You gave me a bunch of exercises, and I did read them. I have found that working on the floor, doing basic stretches, whether they're yoga related or Feldenkrais related or PT Alexander related, there's all kinds of. I find if I go to the gym and I go to the floor, almost everybody's doing the same kind of combination of back.
I don't think there's a magic combination. Just do something. And if you spent 5 minutes a day doing some type of basic core work and some stretching, which is also important, it's going to pay dividends.
It'll pay dividends. So just keep your core strong. I'm enjoying the stretches I'm doing, and I'm also enjoying the roller. I'm finding the roller pops me in is almost as good as a chiropractor or a massage therapist. Yeah. So taking a little responsibility for one's back probably pays dividends later in life.
And a good chiropractor can certainly make you feel better. And patients routinely ask that question, how I feel about chiropractors. Well, I can't trash them because my mother is one. So
even my mother is one. I love it. Some of my best friends are chiropractors.
And my standard line is, if a chiropractor can fix you, you don't need me, which is true.
Beautiful. I love it. I love it because, like, people need to realize as surgeons, we only want to work on people we can help. We have zero. As long as we're busy, they're busy surgeons like you and me. If we don't need to operate, we don't want to do it. We want to make sure we can fix it and make it better. Have a good shot at it. Yeah, I think people need to realize that. We don't want to do unnecessary. Nobody I know wants to do unnecessary surgery. So, all right, how about mattresses? I mentioned mattresses. Any thought on firm or soft or water or air pressure or springs or foam? I see all these ads on TV, John.
I don't really have a strong feeling about it. I think whatever works for you. People probably hang on to mattresses a little bit too long and they get worn out. But it seems like most of the modern mattresses have a little bit of a memory foam topper, which is fine. I don't think there's and certainly our academy has not come out with any official recommendations.
I guess if there were data, they'd say something.
They'd say something about it.
Interesting. So that's a good segue. I don't think you or I are pain treating doctors. But we have people that come to us with painful conditions that are symptoms of an underlying problem. And if you fix the underlying problem, generally you can improve the pain. So pain isn't necessarily the goal, it's more of the symptom. So if a person, I want to know, when should a person seek out an orthopod or an orthopedic surgeon? What types of back pain should one be concerned about?
Well, the things that we typically operate upon are in the low back, it's buttock and leg pain, typically associated with numbness, tingling, or weakness, but perhaps not. But
any particular part of the leg, the front or the back or the inside?
It depends on the level of the lumbar lesion. It's not the patient doesn't need to be concerned about that. But
okay.
One of the standard rules of thumb is that if a patient has groin pain, it's typically from the hip joint. Whereas pain in the buttock is generally from the back. It's not 100% true, but probably 90% true. So frequently the hip surgeons and the back surgeons toss patients back and forth. And likewise, the shoulder surgeons and the spine guys toss patients back and forth, because in the cervical spine, The analogous,
That's the neck.
the neck. The analogous complaint would be shoulder and arm pain. Frequently, the pain, and there's some differences, but and there's a lot of overlap. A lot of patients that have rotator cuff pathology or joint pathology also have cervical spondylosis or arthritic conditions, and these symptoms can overlap. And sometimes they're difficult even for practitioners to sort it out. Yeah. Which one is the predominant complaint?
Yeah, that happened to me. What it was ended up being my rotator cuff that Pat Smith took care of was showing up as neck issues. We kind of had to go through the neck thing. So, well, the pain was coming from here. So it can be tricky. It's not obvious. It's
not always obvious.
Yeah.
No. So in the neck, things that we operate on are typically shoulder pain, and some people have the full-blown classic symptoms of pain that radiates all the way to the hand, and there's different, what we call dermatomal distributions, where the pain radiates associated with different nerve roots in the cervical spine. But not everybody read the textbook, so there's a little bit of a constellation of symptoms that we might see.
Do any stories come to mind, or so it's something really crazy? You thought it was X and it was Y. Have you had any really tricky diagnostic puzzles that come to mind?
We do get some tricky ones. I had one patient that had an unusual presentation. She had some symptoms in her knee, her thigh, and she was a lady in her 60s or 70s probably, and she was explaining to me that if her husband rubbed her thigh in the proper way, that she would have an orgasm.
That's a good one.
So she had the orgasmic knee, which kind of went down in the annals of our best stories. As I was talking to the lady, I
started rubbing her knee.
I said, is this the knee? She said, that is the knee.
Don't touch it.
That's the knee. And her husband is sitting over there, and he didn't say a word. And she's a very talkative lady, and she says, "Is that it? Is that it? Is that it?" And he just nodded his head. Yep, that was it. I said, "Well, I told her, I said, I'm not really sure what's going on with your knee, but I am real certain that it's not orthopedic." And she seemed to be okay with that explanation. So.
Oh, I love it. I love it. So, let's say you're a parent and your child, 10, 12, 14 years old, starts having some back pain. What's this? I remember going out for athletics, you'd have to go to the doctor and cough where they're looking for hernias. But aren't there actually programs to check for scoliosis, like in schools or pre-sports? What's that all about, John?
There are. Actually, Bob Gaines started that program in the state of Missouri, and it's a forward bend test where you're looking for a thoracic hump. When you bend a patient over that has scoliosis, there's a rotational component to it, and you'll see when you bend a patient over, you'll see an asymmetry in their rib contour, and there was a little simple tool to measure a scoliometer, and you measure the angle. And if it exceeded a number, and I forgot the number, the school nurse would send them to be evaluated.
So even a nurse could see it?
Yeah, any person could see it.
And it's common enough that it warrants a general screening, so it's not something that would be painful, that would be brought to your attention?
Very easy screening test. And then the idea was that the earlier you would catch these patients, you could brace them more effectively. And potentially avoid surgery for some of them, rather than letting this curve advance, and then you'd have a tougher case to deal with surgically.
I see. So I'm looking at a word came up in children with back problems. It was called spondylolysis.
Spondylolysis.
What is that?
That's something that I do see frequently. So in the peak growth years of a youngster, which is typically puberty, it is not uncommon for a patient to sustain a stress fracture, which is a repetitive movement problem. Not unlike if you took a paperclip and just worked it back and forth, eventually the paperclip would fail.
What part of the spine is fractures?
It is
The body?
No, it is a piece of bone that we call the pars interarticularis, which is the part between the articulations, which is the part between the facet joints. And this is a lumbar spine, so this is a cervical model. But
Okay.
there is a little piece of bone that's maybe 10 millimeters or 15 millimeters by 5 millimeters thick at the most, that is in an anatomic tough spot. There's a shear stress that occurs through this piece of bone, typically in the lower segments, most commonly at L5, some less likely at L4.
The lower back.
The very low back, right before the sacrum. And the patient will develop this little stress fracture. It could be unilateral on one side, or it could be bilateral. And eventually, because that functionally detaches the posterior elements for the facet joint, the inferior articular process is no longer attached to the vertebral body because of the fracture. A secondary condition develops called spondylolisthesis, which is where the spine slides forward. So in orthopedics, we like Greek words, and the Greek word for spine is spondylos, and the Greek word for slip or fall forward is olisthenon. So we kludged these two words together and came up with spondylolisthesis, which is a very common thing that we treat in spine surgery.
And this is painful?
It is painful almost always. Frequently, the pain subsides, and the patient may go on for years without much pain. And then as the slippage progresses, they develop symptoms in adulthood. And we'll frequently see patients in their 30s, 40s, 50s, 60s, 70s who have been relatively quiescent with regard to their symptoms for perhaps decades. And then as the degenerative processes accumulate at that segment and the slip progresses, they become symptomatic later in life, and we frequently operate on those patients.
So this can start in the teen years. And will a child or a teen usually have enough pain to, I hate this word, complain. Complain, folks, is not complain. It's not kvetching. My Yiddish friend, it's not kvetching. It means, gee, you tell somebody that
this
is
not. Yeah, this is not just the soreness from working out. This is a pain. Yeah, this is
not somebody just being malingering or trying to get out of school. This is a real pain.
Real pain.
And how do you diagnose that in a teen?
Well,
on your fancy MRIs?
You can see it sometimes on MRI, particularly before the fracture actually occurs. You can see it when it's still a stress reaction. You can see it on CT. Sometimes you can see it on plain film, particularly after the slip progresses. Difficult to see it before the slip progresses.
So if you've got a teen with back pain, typically they'll go to their family doctor, their primary care doctor. The primary care doctors very good about ferreting this out and sending them to you?
I think some are, and it's one of those things that if the symptoms persist, these are frequently athletes, and it's usually the parents that are bringing them in because they've been complaining to the parent, and the kid frequently can't participate in their sporting endeavor, and that's what drives the train.
And is the pain like in their back?
Pain is in the back, sometimes in the buttock and thigh.
The low back, buttock pain, do not ignore it. Go to your primary care to see if they should refer to you.
Right, if it's really stopping what you're doing and it's pain, not just soreness. Yeah.
Gotcha. And I assume there's spinal trauma that can occur anytime in someone's life. Do you ever have to repair a back that's been injured in a car accident or something, or an athletic injury?
Well, we really, in private practice here, we don't deal with high energy trauma, which would be burst fractures or flexion distraction injuries. Those are
really bad back breaks. You want to send those to a university with a multidisciplinary team.
Correct. Those tend to go to the university because they tend to be what we call level 1 trauma. These are high energy events, and it takes a big support team to take care of these people because they're almost always have other injuries as well.
Gotcha. Something I learned, I moved to Missouri almost 17 years ago, and I saw a person who was in a motor vehicle event and had been injured, and I used a New Jersey term. I said, "So, ma'am, you were in an accident?" She goes, "No." I go, "I thought you were in a car accident." She goes, "No, I was in a wreck." I said, you know what? You're right. That was a wreck. That wasn't just a fender bender accident. So I now use the term wreck for that. Now I see the medical term is high energy event. I like that. I like that. So as we get older, our backs get weaker. They start to degenerate. I know I've lost about an inch in height. I used to be 6'2.5". I'm just pushing a little over 6'1". Now the spine, it seems to be, it's a stack. It's not coins because coins are thin, but it's a stack of these vertebra that I'm sure we're all aware of. And between each vertebra is a disc, a spongy, somewhat springy disc, right? I guess as we get older, we lose some of that spring, and they just kind of shrink a little bit, right?
They do. The disc has two parts. There's a tough outer ring called the annulus, which is analogous to the wall of a tire. It has fibrous strands in different orientations. And then the inner part of the disc is called the nucleus pulposus, which has a crab-meaty texture. When we're very young, it's almost like mucus. As we age, it becomes crab-meaty, and then towards the end of life, it sort of goes away. There's nothing there. So the loss of height is related to two things. One is the discs settle, and you lose a little bit of height that way. The other is that the curvatures, the spine is an S curve. There's a cervical lordosis and a thoracic kyphosis and a lumbar lordosis. And that S curve becomes more pronounced.
Well, so there's more curvy, so there's a little shrinkage that way.
As you get curvier, you get shorter.
I see. So it's a shorter distance between A and B.
Yep.
So those are the discs between, and then there's the body of the vertebra themselves, the bonier part.
Correct.
Now, can that also start collapsing? And
certainly, and typically that happens later in life, typically, as people get osteoporosis.
Which is about 10-to-1 women to men. Is that accurate, or is it 5-to-1?
No, it's probably 10-to-1. Heavy hormonal influence, but also other factors. The big controllable factor is, one of them is vitamin D, which is really critical for bone health. And I actually measure vitamin D levels on the patients that I operate on. So I can tell you with certainty that vitamin D deficiency is an absolute epidemic in this state.
Yes. Well, it's probably the country.
In the country. So the lab values for normal are 30 to 70, but the bone gurus, the fellows that study this extensively, think that the more optimal values to be 50 to 90.
Yeah.
And if you don't take a supplement, you could very well be in the single digits or teens, maybe in the 20s.
Or you stay out of sun. And
if you got enough from sunlight, the dermatologist would yell at you about getting skin cancer.
And I'm going to have some podcasts in both of this, but there's two conditions that in which I believe the recommendations of one medical specialty have had tunnel vision, and they've looked just at their issue, and they've not looked at the broader, like something like an all-cause mortality. Like they'll look at just heart attacks, so they won't look at all-cause mortality. And I know it drives the dermatologist crazy, but sunlight is so important, direct sunlight, and especially for our African-American brothers and sisters. They need to get a lot of sun. I'm going to bring on some sun gurus myself, but I think the dermatologists have not looked at all-cause mortality. And the bone health is just another aspect of health that have been ignored for the sake of skin cancer.
But vitamin D is cheap and easy, and
that's the argument. But there are other things. Sunlight gives us other things.
Right. I'm not anti-sunlight.
Right. I just want to make this good. And this is a healthy argument. But I think they've told us we can get it from a bottle or what have you. And I guess it's better from a bottle than not having it at all.
Absolutely.
As we can all agree that we need good amounts of vitamin D to maintain our bone health. So you've got the bony part of the vertebra, and we've got this spongy disc between them. Now tell me, what is a slip disc? Do discs slip, or is that the term for a bulge or some other problem with the disc?
Typically is not a word that we use in the profession, but
yeah, I never hear you use it.
Most people are referring to this condition we just spoke about earlier, the spondylolisthesis, because one vertebral body has slid or slipped relative to the other.
So it's not the disc, it's the bodies themselves.
But they slide through the disc. That's where the translation happens.
I have a cousin. This is a good time to talk about another story. I have a cousin. She's very, very dear to me. I was supposed to be the first cousin of my generation. I stayed in a little long. She came. So she was actually the first cousin in my generation to be born. I've never heard the end of it. But poor thing, she's had some health issues. And her head was just kind of leaning forward a little more over the years, and no one said much of it. She got this real neck ache, and her head, I guess, her chin was out like this, and her head was just always kind of slanting down and slanting forward. And she went to the doctor, and they took an x-ray. John, I think I showed it to you. Her spine had slipped so much in her neck that when they read her x-ray, they were saying, hey, come back next week. They called her at home and said, can you come in immediately and don't get in a car wreck on the way? Because she was literally about to dislocate and literally fracture her neck. It was about ready to break because it had slipped so far in her neck. And I showed you that x-ray on my phone.
It's really unusual in the cervical spine. And it can give rise to a chin-on-chest deformity, which is a major problem to deal with surgically.
Chin on chest. That makes sense. That makes sense. You've seen things like that. So obviously keeping our bones strong, vitamin D, I assume exercise, weight bearing, all that stuff. So as we get older, other things can happen. I will say Dr. Miles also took care of my daddy when he was alive. And my dad had a bunch of back problems. He had so many back problems. John told me he could have done a whole fellowship just on my dad's back. He had all these problems. So I want to learn more about all these things that you do, John. So when these vertebrae start coming closer together, they start compacting, maybe fractures and what happens and what have you. And tell me if I'm correct, there are these big nerve roots that come out of the side, out of the spinal cord between the vertebrae, right?
This is true.
And they are called roots. And the word for root in Latin is where we get the word radical. Radicals actually get to the root of issues. And in fact, there's something called radiculopathy, which sounds to me in Greek like disease of a root. So tell me about radiculopathies.
Radiculopathy is something that we treat routinely. The model that I have here in my hand is the cervical spine. So the spinal column is a series of little building blocks separated by intervertebral discs.
Okay.
And in the neck, just like throughout the spine, the nerve holes or the nerve foramen where the nerve roots exit, these holes are not particularly large to begin with. And if you grow a little bone spur or disc material into the nerve foramen, the nerve root loses the battle and frequently will manifest as pain. And the pain from nerve root entrapment is what we call radiculopathy, which is typically characterized in the neck as pain under the scapula or subscapular pain.
That's behind the shoulder blades?
Behind the shoulder blades. You kind of feel like it's under your shoulder blade, typically. That's the way patients describe it. And the pain frequently will go down the arm, sometimes even down into the hand, and can be associated with other symptoms of nerve root dysfunction, such as numbness or tingling or weakness. And we look for certain patterns that fit certain nerve roots. They tend to have some classical patterns, which is confirmatory of our clinical suspicions based on our total evaluation of the patient, which starts with a good history and physical examination findings. Imaging studies are all part of that. And there's a subset of these patients that we can help surgically.
So you got to decompress. So it's a tight spot. It gets too tight. This nerve root gets pinched, gets damaged, injured. So if you have a tight nerve, what can you do?
Well, the only thing that you can do anatomically to change that is surgery. Typically, we don't start with that. We usually start with medications and injections to see if we can calm it down a little bit. But the end game is surgery for these conditions.
Now I see things on TV for these these inversion tables you hang by your feet.
And that can give some temporary relief.
That can give some temporary relief. So that could maybe, if you're doing it right and you're strong enough, and you're not going to get you don't have an aneurysm in your brain that you're
not going to have a stroke.
You're not going to have a stroke hanging upside down for a while. So there's an act that's a real thing. You're saying inversion tables and whatnot.
It is. I'm not sure how practical it is, but the front of the line is typically injections, and sometimes you get lucky, and these injections work for quite a while.
And those will reduce the swelling and give it more room.
No, they don't change the anatomy at all. They're just really potent anti-inflammatories. They just reduce symptoms. But that's valuable. If the patient doesn't have a deficit or some functional deficit, then if we can get rid of the pain, that's not a bad deal.
You give lots of injections in the office?
We don't do them in the office, particularly in the neck. We need to use image guidance with x-ray because we don't want to poke the spinal cord. So we use a little dye, and one of my colleagues will do this. I don't do these myself.
Because you have a specialist in your office that's really good at this.
We have several, actually.
Several?
Yeah, we have typically some radiologists will do this, or we'll have we have a pain management physician who does a lot of injections. And so we order these many, many times a day.
Gotcha. And you can give real relief with that.
They do.
Fantastic. Now, let's say it's really, really pinched and you have to do surgery. How do you open up that space to give that nerve room?
The way we do this is we remove the central part of the disc all the way back to the canal, and we trim out the disc and the bone spurs that are putting pressure on the nerve roots. And then we establish normal height because these discs are always collapsed.
Okay.
And then we jack them back up to their normal height, which directly opens up the neuroforamen.
Is that a fusion?
Well, this is the fork in the road. The traditional option is a cervical fusion where you put a bone plug in the disc space and then typically a plate and screw construct on the front, and you get the bones to grow together, which works very well for pain control, but it does give you a stiff segment through there.
Now you can't move that spot. So now there's more stress on the next vertebra up and down.
This is true. So in the last 20 years, there's been a fairly significant push towards motion-sparing alternatives, which are disc replacements. So the same decompression is performed, but then instead of putting the bone plug and the plate and screw in the disc space, we insert a little metal plastic device that keeps that segment mobile.
Well, I was going to get to this at the end of the talk, but let's talk about it right now because I just love this. And I know people come to you from far and wide to do this because you're one of the busiest, most experienced surgeons in the world doing this. So tell me, so what you do is you've got this compressed disc between the vertebrae, compressing that poor nerves, causing other symptoms. You then can pull apart. I think it's called distract. You can then distract the vertebrae. So you make a little extra space.
Correct.
And then you take out the whole old disc, that fibrotic, worn out tire there.
Take it out, and then we go back and trim out the bone. There's almost always bone spurs as well that we trim out.
So you've got special little grinders and tools in there. Mm-hmm. And you want somebody that does this all the time like you. This isn't just so you've got the expertise to go in there and make a new perfect space, I guess.
Correct. That is what we do. And there's lots of us that do that. And it's the same decompression for the fusion as for the disc replacement. The disc replacement is becoming the new gold standard. It's been slower than I had hoped to catch on. Our institutions are fairly hidebound in that regard, but every study that's been done comparing cervical disc replacement to fusion has shown equivalence or superiority of the disc replacement.
What's this disc replacement made of?
There are several designs that are on the market now. The one that I'm currently using is made out of 3 parts. There's a shell on the upper and lower end that's made out of a plastic material called PEEK, polyethyl ether ketone, which is an inert plastic that's been around in orthopedics for a long time.
And it's strong as hell.
Very strong, and it has good, very good surface characteristics. It's highly polished and very little wear debris with it. It has a titanium mesh coating on the surface for bony ingrowth. It feels like fine grit sandpaper, and there's some little mechanical teeth that dig into the bone. And this mesh coating allows for quick ingrowth of bone into the mesh coating.
There's an interface there.
There's an interface.
Okay.
And then the central core is made out of a zirconium ceramic that is, again, high surface smoothness. So
that sounds stiff. Doesn't sound very springy.
There is no spring at all. It's just motion. But that's really quite adequate. Again,
So
most of the spring in the spine actually comes from the shape of the curve.
So you've got this just kind of you described sounds like a sandwich, and between those two, between the zirconium and the peak, there's movement.
There's movement. So it wibble wobbles. It can rotate. It can flex, extend, lateral bend, and it's not a lot of movement. It's about 10 degrees.
Well, you don't need much. It's not moving that much anyway.
And so a lot of patients will ask if these things are going to last a lifetime. And the answer is we don't have 30-year clinical data in patients. But we do have very good mechanical testing data from the FDA studies. And we believe that they will last a lifetime because the loading circumstances appear to be below what we call the endurance limit. In other words, we're just not doing enough to the device to wear it out. Gotcha. And it's not a surprise result because the circumstances are so much more favorable in the cervical spine than, say, in the knee or the hip, where the mechanical testing models, fairly accurately predict the failure of those devices when they occur. But if you think about the circumstances in the cervical spine, the contact stress is way less than in the hip or the knee. The arc of movement is way less, 5 or 10 degrees versus 100. And the number of cycles in a lifetime is much less.
It reminds me of a car commercial. I think it was Mercedes, where they have this machine opening the door and closing the door. Slam, open, slam. So you can do 1 million tests.
And we have machines that do it.
You've done that.
And the machines do it. And when you don't stress it that much, which in the neck we really don't.
Is that the weight of the head? You don't have the weight of the body there.
And it's just not that much. You don't have the impact effect of ambulation. So when you're walking or moving quickly, you're transiently really loading these things up. When you have contact stresses across these joints where the muscles are acting across the joint also, you just don't have that in the neck.
So how many years ago was the first one you really did? When did you start really doing this routinely?
Well, I've been doing it for 20 years, but 20 years ago it was in studies, clinical studies.
So you had access to pre-release, in stuff. I don't forget what you call it, it was in a study. So 20 years ago, you said you started doing this?
COG's been involved in several clinical trials. One of the early discs was the Bryan disc, and we were involved in the ProDisc study and the PCM study, and I was involved in the Charité lumbar study.
So you've been doing this personally for 20 years?
Correct.
And so you've had patients that have had these in their bodies for 20 years?
That would be true.
And you're seeing durability. They're durable.
I have seen durability. I've had to revise very few of these devices over the years.
Now, do you sometimes have to do more than one level? You do just between two vertebrae. I assume sometimes you do two.
The current insurance limitations are typically at 2 levels. And that has transpired, as you're aware, back in the day, insurance companies didn't dictate how we practice nearly as much as they do today.
And I want to tell you something. I hate insurance companies, so say anything you want.
So it used to be that if a device was FDA approved, that a physician or surgeon could use it in any way that they thought was appropriate.
Right.
That's no longer the case.
Which would seem appropriate.
That would seem appropriate, but that's no longer the case. So today, the insurance companies tend to follow FDA guidelines, which were never intended to dictate how we practice medicine, but that's how they're used now. So unless a device has an FDA approval for 2 levels, most insurance companies will not pay for it.
So you haven't proven it's good
Yeah.
for 3, therefore,
Right.
even though it's good for 1.
And so they also tend to push back if you do a disc replacement adjacent to a prior fusion. We tend to get pushback still. But nonetheless, it's still better than it was even 5 years ago when we only could do 1 level typically.
Okay.
But now we can do 2 levels. And for the even if a patient has 3 or 4 level disease, usually 2 of them are worse than the others.
Okay.
And I'll lay the options out to a patient and explain that we could do a multi-level fusion, or we could just treat the 2 worst ones with disc replacement surgery. And almost invariably, people select the motion-sparing alternative. There are really just 2 major caveats to disc replacement surgery. So one is instability on flexion extension films, which is that condition that that word we used earlier, spondylolisthesis.
Okay.
So if there's a slippage or a spondylolisthesis, that's a contraindication to disc replacement surgery. The other contraindication would be advanced facet arthritis in these little stabilizer joints on the backside. So at every motion segment in the spine, there are actually 3 joints. There's the big disc on the front,
Okay.
and then there are a pair of these facet joints on the back.
So let's describe the spine. We have this stack of vertebral bodies up and down, almost like a multi-segment, almost like a snake with multiple segments. But then off the back, there's these wings that stick back. There's 2 that go to the side and back, and 1 that goes straight back, kind of like the Stegosaurus.
Correct.
And these facet joints are kind of between these the back. There's 2 of them in the back where the 2 wings below kind of contact the wings above. I know that's not a perfect description.
That's true. So the transverse processes go off to the side.
Okay.
And then the spinous processes in the midline, and these are all muscular attachment points.
Okay.
And these are the levers that the muscles use to act on the spine.
Makes sense.
Yeah. So these facets are stabilizer joints, and they add stability. They limit movement. But we need to have good functioning facets to support a disc replacement. The disc replacement does a great job of replacing the disc, but it does nothing for these facets. So if a patient has very arthritic facet joints, that is a relative contraindication to disc replacement surgery. And unfortunately, we haven't really defined how much is too much. I do obtain a CT scan on patients that I'm taking to the operating room to better evaluate these facets, because you can see them a lot better on CT than you can on MR or plain radiogram. And I just use my best judgment and talk to the patient about that based on the condition of their facets. But the spondylolisthesis, in my mind, is an absolute contraindication. And the facet arthropathy is a relative contraindication. But that's the bugaboo.
So you have to very carefully evaluate these patients before you take them to the OR, is what you're telling me.
Correct.
So you have to choose your patients very, very carefully because we want the best outcomes. That makes a lot of sense. Now, what is cauda equina?
So that means horse's tail. So the cauda equina, the spinal cord terminates about the L1, L2 segment.
So your spinal cord doesn't go all the way down. It goes kind of through your middle back, and then it stops.
Then it stops, and then it terminates in what we call the cauda equina, or the horse's tail. So in the lumbar spine, throughout most of the lumbar spine, there is no cord. It is a nerve, it's a sac with nerve rootlets in it.
So it's like a mop of nerves
nerve
coming
rootlets
down.
That coalesce at each segment to become nerve roots. Some of these fibers coalesce, and then they exit as nerve roots.
So what can go wrong there? There's like I read that in elderly people you can have a disease of the cauda equina. Does this refer
Well,
to
cauda equina syndrome is...
Yes, what is that, please?
Is where you have a severe compression of the nerve roots. It can occur at any level and in the lumbar spine, and the patient manifests classically with loss of bowel or bladder function, but also typically deficits as well, strength, motor, and sensory deficits as well.
So if an older person has weak legs or they're falling down, they need to be properly evaluated, and they may have tight. Now, is this once again just tightness of the roots? Is this a radiculopathy? Is there something more?
Well,
to it?
radiculopathy is much more common, and that is pressure on a nerve root that has pain down the leg. Cauda-equina syndrome is actually a very rare condition. It typically impacts younger people when it does occur, and it is not common in the least bit. But but it is a medical emergency or a surgical emergency, and the sooner you can get those people decompressed, the quicker they respond.
How do you decompress? I guess.
Well, it's typically due to a very large herniated disc, where some of the nuclear material has extruded back into the canal, and the canal is pretty well obliterated. There's really no space, and so you have to move the nerve sac out of the way and remove that fragment, the offending fragment.
So you're in the central nervous system there. You're in the spinal cord area then.
That's correct, yeah. Well, nerve roots.
It's in the nerve roots.
But it's severe central stenosis due to a very large herniation is the typical way that we see that. And again, it's a rare condition.
Now, are there any of the common back problems that you take care of, John, that I have not addressed yet? Are there any things that you see commonly that that my audience should know about that I haven't mentioned yet?
I don't think so. This normal degenerative disc disease, everybody has as we age, and these people don't need surgery for the most part. That's just not. That's not what we call an indication for surgery.
In medical school, we have this real fun activity. It's called Stump the Professor, where it's a chance for the students to get back at the generally guys, but they can be gals, and generally the gray-haired people who are the chairman and the department heads and all this kind of stuff. And it's a common thing where we'll put the professors up there and we'll give them a case that's very difficult and see if they can figure it out. In fact, New England Journal of Medicine has this it's an actual series. They have one every month on guess the problem. And I saw this patient. I'll never forget it. I was a medical student. I'm going to see if you can tell me the diagnosis, John. He was, let's say, late middle age, normal weight, basically healthy African American gentleman. He'd been having some lower back pain, nothing to write home about. And then suddenly he was going about his normal activities and he just collapsed. His legs gave out and he collapsed, and they brought him to the hospital, and his legs were really weak and there was something wrong. So they admitted him to the hospital and they were doing all these tests, and he had been admitted that night. So we were doing morning rounds, happened to be on internal medicine rotation, I believe. And so all of us, a dozen of us are around this guy's bedside. The attending is presenting the case. The resident's presenting the case, and the attending's giving feedback. And usually the attending will say, "Well, I think it says right in front of the patient," but he didn't say anything. So he said, "Thank you very much, sir." And we all walked out of the room and went out to the hallway where we were down the hall, out of earshot. What do you think the diagnosis was?
Well, it's the first thing that I would want to rule out is what we call cervical spondylotic myelopathy. So
that's a big one.
That's a lot of words, but a classic or pure myelopathy, which is where the spinal cord is being compressed in the neck, those patients in some cases will not have pain whatsoever. Their legs won't work, and
legs just give out on,
and they'll not be able to walk. And there's some physical exam findings that you'd look for, but a classic case, the patient has no pain whatsoever, and they just can't walk. We call it ataxia.
Interesting. Now, I didn't mean to put you on the spot right now, and I'm not giving you maybe enough of the history, but I'm bringing up this story to give people hopefully people will appreciate how hard diagnosis can be and how important it is to have the patient in front of you, to take the time to listen to them, take the time to examine them, take the time to do the right tests and whatnot, and then have the humanity not to hit them with something terrible and figure out how you're going to tell them about the diagnosis. But I'll never forget this. We go down the hall, and as a medical student, I'm thinking primary spine. I'm thinking all these other things. And the attending says, I think he has prostate cancer. And it was like, if you said it was a space alien colony in his spine, I would have thought that would have about the same likelihood of prostate cancer. But he was an otherwise healthy guy. He was a black guy, and they don't get enough sun. They typically have low vitamin D, like you said, and they have a high rate of prostate cancer, maybe due to low vitamin D. And prostate cancer likes to metastasize to the bone, like breast cancer does.
That's true.
And I was blown away. My jaw hit the floor. I had my little short white coat, brand new, and my brand new stethoscope and knee hammer and ophthalmoscope. I was this brand new medical student, and I was just gobsmacked. Prostate cancer. And then they got the markers and the alk phos, these things. When bone gets eaten up by cancer, it lets out these various chemicals you can measure. And wouldn't you know, it was prostate cancer manifesting as a spine issue,
which I see a couple of times a year.
Yeah, yes. I want people to know the body is so complicated and interconnected that having an experienced doctor who's been around the block, who's done training in internal medicine and general surgery and mechanics and physics and fellowship. I mean, it all comes together. And what I'm doing is I'm making a plug for experienced doctors still running the show and not having necessarily physician extenders doing all the basic medical care. If you have a basic run-of-the-mill problem, maybe a basic run-of-the-mill diagnosis will do it. But there are still these cases that are not that uncommon where somebody has something completely out of the blue, a complete curveball, something you'd never expect, left field, that comes at you, and it takes an experienced doctor to be able to make the diagnosis. So I wasn't trying to put you on the spot, John. I was trying to make a point how difficult diagnosis can be and how important an accurate diagnosis is for the health of our patients.
Very true.
And you must see a whole bunch of one thing masquerading as another, and we're dealing with older folks that you and I, we're both almost the same age, you and I, and as we get older, I hope there's good young doctors who are experienced enough to help us through our problems, which may not be so easy to diagnose. So I'm thinking, is there anything else is there anything else you would like to mention about spine surgery that you'd like the general public to know?
I think we covered the waterfront. I think we hit the high points, and we could talk about it for months, obviously.
But obviously, you spend a whole lifetime learning how to do this.
Yeah.
And
probably the biggest change that happened in my career was the advent of these motion-sparing alternatives, and that's become a big part of my practice.
Yeah, because I want to say that people are very, very happy, and I know you're very busy doing that. Oh, I know I had one more question. This spine, the cervical or the neck portion of the spine, is right in the middle of the neck.
It is.
Seems it's a truism, but it's so important. It's right in the middle of the neck. It's surrounded by the rest of the neck, your trachea, your blood vessels, all these nerves and arteries. How do you get there, John?
So
how do you know where to go?
It's somewhat shocking to patients how really easy it is to get there. We make a paracentral incision on the front side of the neck. The only thing we incise is really the skin. After that,
is it a horizontal incision on that?
It is.
Vertical?
We go horizontal because cosmetically that's much more appealing.
Okay.
And we try to put it in a skin fold.
Uh-huh.
And then we really just mostly bluntly dissect, and we push the trachea and the esophagus out of the way. And the blood loss is typically trivial. We make up a number, and we don't cut any muscles.
And you just push things away.
We just push things away. And
so you're able to separate the breathing tube and the esophagus and
we move them together.
Arteries.
Yeah, the carotid sheath. You work around that, and you're looking at some big vessels, but we don't go into them, and we just push them out of the way. And we have specialized retractors, and we're looking right at the front of it.
So right there, so you go. So for these disc replacements, you're going through the front of
and the fusions. Just most of the fusions we do on the front side as well.
So tell me just a little bit more about fusions. As a medical student, I remember being in there, and they would take a piece of bone out of the hip. They'd have this
typically
this special saw, and they would saw a slice of hip out.
Typically, we're using synthetics these days.
So not
I have not actually taken a hunk of bone off somebody's pelvis since I've been in practice, because I want patients to like me, and
that hurt most. Afterwards, that hurt the most. I recall.
They will not like you for doing that to them.
So you synthetic, is that cadaver or an absolute synthetic?
Both. There's several. There's a myriad options available now.
Now I heard something about cages. These
frequently
objects they put in there to hold the
frequently we
apart.
use synthetic spacers, frequently made out of a substance called PEEK.
Okay, PEEK again.
PEEK. There are other materials. Titanium mesh is one of them that's popular, but then we use it as they're usually hollow. We pack them with some type of a bone graft.
Okay.
And they work very nicely for patients that need a fusion.
Now, do you ever do? I think it's called a kyphoplasty, or where you can puff the vertebral body back up. Is there something you can inject? What's that called? You're the doctor.
So that procedure was very popular probably 15 years ago.
Here it is. I wrote down kyphoplasty.
Yeah, kyphoplasty. I actually did the first kyphoplasty in the state of Missouri.
How fantastic.
And I think for the right patient, it probably does. It probably is a reasonable option. The natural history of the condition of that procedure is used to treat a compression fracture, typically in an older lady.
Right.
The natural history is that they heal on their own, and that's kind of the knock on the procedures. That if you just would have waited a few weeks, they heal up anyway.
But doesn't it heal compressed though? Can't you give them more height?
It does. That part of it has been more elusive. To get much height is difficult. If you catch some fresh fractures that you're pretty aggressive with the balloons to blow them up. If you catch them early, you can restore some height, but for the most part, you're really just creating a void in the bone to put the bone cement in. And the height part has been more elusive.
I see. Very interesting. Well, John, I want to thank you for coming and spending time with us. I want to say you're one of the best spine surgeons in the world, and it's a real pleasure to have you as a colleague, a locker mate, and as a fellow physician here at Boone Hospital. You have a great group. You've taken great care of me and my family over the years, and I wish you continued success and continued advancement, and I hope you are able to help people for many, many years to come.
Well, thank you, Gil. It's been a pleasure.
Pleasure.